share her screen. We can start the meeting.
Okay. So my screen is visible?
Yes.
Dr. Kilby, Dr. Khurana, Mentor Emeritus, Society for Fetal Medicine, India, esteemed members of the Stillbirth Society of India and the Society for Fetal Medicine who have joined together, chairperson of the Committee for Study of Stillbirths in Multiple Gestations, Dr. Aparna Sharma. A very good evening to all of you. And it's my pleasure and privilege to be here today, collaborating with the Society for Fetal Medicine, along with the Stillbirth Society of India, and to have our esteemed guest, Dr. Kilby, today amongst us. Thank you very much for joining, Dr. Kilby. Before we begin, I would like to introduce the chairperson of the society, of the committee, Dr. Aparna Sharma, young and dynamic additional professor from the prestigious All India Institute of Medical Sciences and part of the fetal medicine unit. She's a specialist and expertises in fetal interventions. She's also the Secretary Society of Fetal Medicine, chairperson of the Multiple Pregnancy Committee, Stillbirth Society of India, chairperson AOGD Quality Committee. We all know her passion about quality improvement. North Zone Coordinator of Safe Motherhood Committee, co-convener Early Pregnancy, SIG Indian Fertility Society, Kamini Rao Orator, Junior Chorion Award winner, Foxy's son, IAC Traveling Fellowship Award winner, Legion of Tomorrow Award by the new North Zone Foxy Imaging Science Committee Award winner, and Rajat Ray Award in Fetal Medicine. She was also the Joint Secretary of AOGD and North Zone Coordinator of Practical Obstetrics Committee, member Fetal Medicine Subcommittee, member Executive Committee, Society for Fetal Medicine, and has many publications and international peer-reviewed journals. I now want to introduce the other members of this committee. Her secretary is Dr. Reema Kumar from Cloud9 Hospital, Dr. Chinmay Omarji from Pune, Dr. Piyush Bansal from Nagpur, Dr. Kavita Koiwal, Rishikesh, Dr. Anubhuti Rana, Delhi, Dr. Shilpi Nain, Delhi, Dr. Rinchen Zangmo, Delhi, Dr. Dipali Garg from Delhi again, and Dr. Nimisha Agarwal from Delhi. So we have committee members who are going to work towards this, and Dr. Aparna Sharma is now going to talk about her vision for the committee and where she's going to take us with this, with the Stillbirth Society of India.
Thank you, ma'am, for this introduction. So a very warm welcome to this webinar. Professor Kilby, we're really honored to have you here. Just a brief introduction to the committee. Multiple gestation is an extremely unique condition for the mother and the baby. And this committee is really unique because it actually brings together the seer and the doer. And hence, the purpose of this committee is to actually bring together the like-minded people to disseminate simple good practice recommendations. We are not actually being very ambitious, but we want to bring together the fertility societies, the radiologists, the fetal medicine people with the obstetrician to just do simple things which can improve the outcome of twins. And think about releasing simple messages, newsletter with simple messages. With this brief outcome in our mind, I will not keep the audience away from listening to Dr. Kilby further. And I would now like to introduce the session expert for today, which is none other than Professor Ashok Khurana, sir, who we all know as the Mentor Emeritus of Society of Fetal Medicine. Sir is an ex-Amsonian from All India Institute of Medical Sciences, trained in Denmark in ultrasound. He's the chairman and consultant at the ultrasound lab But more than anything else, he's the senior consultant and the senior member of SFM who has guided a generation of fetal medicine professionals in the country. And people look up to him for fetal medicine guidance all over the country. So, sir, I request you to lead the program further and introduce Professor Kilby, please.
Thank you, Aparna, for that very kind introduction. It's a very special day in the history of the Society of Fetal Medicine, and also a very, very special day for the Stillbirth Society of India to have Professor Mark Kilby with us today. A, we are collaborating on the right lines, and B, we have someone who's right in the middle of things to guide us correctly from the beginning. We do understand that a lot of us do not seem to understand the relevance of a stillbirth, far less that in twins. We also don't seem to want to include it very happily in our adverse perinatal outcomes, and we don't have a reason to not include it. We know it has a huge psychological impact, it has a huge social impact, and most importantly, it doesn't look good in the books and gives the profession a bad name. And this is in spite of the fact that we have evidence to suggest that things can be done. So I'm so glad we've set out with the committee to make sure that we make everyone aware of what is going on within the profession, and make sure also on how to guide ourselves and have the correct guidance. I'm so glad to have with us today to kick off this project, Professor Mark Kilby. For those who don't know him, you should be ashamed for not knowing him, really. He is, of course, Professor of Maternal and Fetal Medicine at the University of Birmingham, with a huge amount of great projects to his credit. But most importantly, he is an excellent teacher. I'm sure the messages you're going to take home today are going to be very, very important messages that are going to change the way we practice. He's also been on the Embrace UK Confidential Inquiry, and we know how much information we got through the publication on that, on perinatal deaths in twins, which was published last year. His other interests, of course, include a lot of procedures in monochorionic twins, and we look forward to having him over again sometime to discuss that. But today, I look forward to hearing him on perinatal loss in twins and the impact of chorionicity. So over to you, Professor Mark Kilby, for your screen share and your presentation on the impact of chorionicity.
Thank you very much. Is that okay? Can you see the screen okay?
Yes, this is perfect, and we can hear you very well.
Thank you very much for your very kind introduction, and it's a great honor to speak to the Society of Fetal Medicine of India and the Stillbirths in Multiple Gestation Committee. I'm going to be talking today about perinatal loss in twins, and in particular the impact of chorionicity, in particular monochorionicity. As you just heard, I'm Professor of Fetal Medicine at the University of Birmingham, and I'm the lead clinician in fetal medicine at the Birmingham Women's Foundation Trust. So we're going to go on to the background. So, right. As you know, twins complicate approximately 1 in 60 pregnancies, certainly in the UK, but there's variation around the world. And the majority of these are twins rather than triplet pregnancies. 20% are monochorionic twins, approximately 80% are dichorionic, and the incidence of twinning is changing throughout the world. In the majority of countries, it's increasing because of 3 main reasons: because of the more liberal use of subfertility treatment, infertility treatment, and even with 1 embryo replacement, that can increase the twinning rates. By deferment of reproductive age, having children, and to a later maternal age, which increases the risks of multiple pregnancy. And also by immigration, by influence of race. Certain races, particularly in sub-Saharan Africa, have greater risks of twinning. And these factors all increase the risk of multiple pregnancies in general, and twins in particular. And of course, twins are associated with increased perinatal mortality and morbidity, as we're going to hear. It's important to understand the relationship between zygosity and chorionicity. As I've indicated, chorionicity is really a clinical description where there are, on ultrasound scan, usually defined in the first trimester of pregnancies, 2 placentae and 2 amniotic sacs, that being dichorionic twins, and 30% of dichorionic twins can be monozygotic, so it's not synonymous with being non-identical. About 70% of about 80% of twins are monochorionic, and all of these are monozygotic. The later the embryonic division occurs after the fertilization of 1 ovum and 1 sperm, the more complicated the pregnancy becomes, with later divisions after 8 to 12 days, leading to monoamniotic monochorionic twin pregnancies. And this is again associated with a further increase of perinatal risk. And then, of course, conjoining of twins, which is later division or incomplete division with very high risks of perinatal loss. Monochorionicity in a nutshell, though, leads to pathogenesis because that single placenta shared between the 2 twins has placental vascular anastomoses that conjoin both of the fetal circulations. And these anastomoses link the 2 twins together. These data are from Kypros Nikolaides' group at the Harris Birthright Trust, and you can see that compared to singleton pregnancies, the risk of twins, the complications of twins is increased, both for dichorionic and then further in monochorionic twin pregnancies. Those of miscarriage, perinatal death, fetal growth restriction, preterm birth, and indeed the major congenital malformations. So much of the perinatal risk is because of these complications. And indeed, Kypros and his then trainee Neil Sabai showed this in a classic document that looked at the cumulative fetal loss and the difference in cumulative fetal loss from the first trimester of pregnancy when there are 2 living fetuses in monochorionic twins and dichorionic twins, and showing on this graph the cumulative fetal loss being significantly increased in monochorionic twin pregnancies. And you can see that perhaps the lion's share of the increase is between 15 and 22, 23 weeks gestation, which is a time when the complications of twin-to-twin transfusion syndrome and indeed early onset selective growth restriction can cause significant morbidity and mortality. These data are from a publication in the BJOG produced back in 2019. That year, there was great fanfare in the UK about the fact that the stillbirth rate and indeed the early neonatal death rate had been halved between 2015 and 2016. And we actually tabulated data from both the CMATCH data, which was the preceding report of Embrace, a confidential inquiry from 2000, the Scottish perinatal database on stillbirth rates for twins, and then Embrace going forward. And you can see from these data that even if you take a rolling average over a 3-year period, the perinatal mortality, in particular stillbirth rate associated with twin pregnancies overall, has gradually decreased since 2000 through to 2016. When you actually look at these data for a correction for monochorionicity, you can see from 2013 to 2016 2 things. The risk of death, stillbirth, per 100,000 total births for monochorionic twins is much higher than both dichorionic twins and singleton pregnancies, but has gradually had a decreasing trend, especially from 2014 to 2016. But actually, the risk of stillbirth from dichorionic twins has fallen below that of singleton twin pregnancies. So why is that actually happening? Why are these trends actually occurring? Well, I think since the late 1990s, there's been a better understanding by general obstetricians and gynecologists, and indeed midwives, as to twin-specific problems, obstetric and midwifery problems. Since this time as well, there's been an importance and a focus upon the importance and the impact, the clinical impact of chorionicity. And that's led to first trimester allocation of chorionicity in the majority of cases, certainly within the UK. It's also, there's also been a better understanding of chorionicity related pathologies and their treatments. So understanding the conjoining of the fetal circulations and treatments for twin-to-twin transfusions such as fetoscopic laser ablation has improved significantly the outcome of these pregnancies. But also there may be other factors that are just associated with vagaries of collection of data. So for instance, the Embrace UK data collects fetal loss, perinatal loss from 22 weeks gestation. And so therefore it is conceivable that the decline in stillbirth rate and the decline particularly in monochorionic twin stillbirth rate might actually be because treatment is initiated, say, between 16 and 20 weeks of gestation. And if the babies are going to die because of the complications of that treatment and the pathology, then they won't actually, they do that before 22 weeks gestation and therefore won't be included in the statistics. So it's not as straightforward as patting ourselves on the back and saying we're doing a really good job. But one of the keystones, I think, for improvement in perinatal mortality overall is the establishment of national and international guidelines which have led to the designation of multidisciplinary twin clinics, certainly in the UK and certainly in many countries around the world. So what are the guidelines that have done this? Well, the first of these is the guidelines that I have actually chaired from the National Institute of Health and Clinical Excellence, NICE. Firstly, when it was initially set up in 2008, which focused upon the antenatal care of twin and triplet pregnancies. And then subsequently, there was an update that was published in 2019, which actually focused both on changes in practice, both in antenatal care, but also focused on intrapartum and postnatal care in twins, which again is very important. In addition, I was involved with my colleagues in this, the most recent one, Leanne Bricker from Abu Dhabi, to focus upon the management of the most pathological twin pregnancies, those of monochorionic twin pregnancies. And that led to the production of a green top guideline, which was published in 2016 and is actually being revised at the present time by myself and Leanne, and will be published at the end of this year. And then finally, the international guideline from ISHWA that focuses upon the good use of ultrasound in the management of twin pregnancies. And I think it's not an understatement to emphasize that the use of ultrasound has made great inroads, perhaps the biggest inroad, into being able to manage these sometimes complicated pregnancies. So what are we'll go through what the recommendations are for some of these managements, and then also looking at the most pathological diseases that can affect particularly monochorionic twin pregnancies and their treatment. So I emphasize that dating and ascertainment of chorionicity on ultrasound in the first trimester is a keystone recommendation from all three of those national/international guidelines. And The dating of the pregnancy is usually by obtaining a crown rump length of the largest twin, and then for using that to date the pregnancy. And then subsequently, the chorionicity of the pregnancy is noted by looking at the number of placentae that you can actually visualize on ultrasound, and whether they're, even if the placentae are butting adjacent to each other, you get the intertwin membrane, which is always much thicker than its monochorionic counterpart, and also the lambda sign, where placental tissue infringes on the intertwin membrane. And two separate placentae, two amniotic sacs. In contrast, in monochorionic twin pregnancies, there is always a single placenta, and this rather thin, sometimes difficult to visualize intertwin membrane on ultrasound, which inserts perpendicular to the placental mass. And the studies that are prospective studies that have looked at this have shown a diagnostic accuracy of being able to define chorionicity of nearly 100% if it's performed in the first trimester, when usual first trimester screening is performed between 11 and 13 weeks and 6 days. Certainly, the guidelines have also stratified the management of twins and indicated a differential management strategy for dichorionic compared to monochorionic twins. And this is the strategy outlined in the NICE guidelines, and again in all of the other international guidelines, where the initial contact of a patient when chorionicity is defined, patients are offered first trimester combined screening for aneuploidy, and then if the pregnancy is dichorionic, the patients are offered ultrasound scans at 4 weekly intervals all the way through the pregnancy until 36, 37 weeks, when there's a national indication to deliver dichorionic twins at that gestational age to avoid the uptick in perinatal mortality. In monochorionic twins, surveillance is more closely monitored by ultrasound, and you can see the same applies when monochorionicity is defined at the first trimester scan, when dating and screening for chromosome abnormalities is also offered. Then from 16 weeks of gestation, the woman is offered scans at 2 weekly intervals, when fetal biometry, amniotic fluid is measured in the deepest vertical pool, and from that gestation onwards, umbilical artery Doppler velocimetry is estimated. In some guidelines, mainly those from the ISHORG guidelines, from 20 weeks gestation, there is also an additional recommendation for adding middle cerebral artery peak systolic velocity measurements to try and screen for TAPS, and also at 20 weeks gestation to offer cervical length to try and predict those twin pregnancies at greatest risk of preterm birth. And the scans are at 2 weekly intervals. Although twin-to-twin transfusion syndrome is rare after 26 weeks gestation, we continue and advise continuation at 2 weekly interval scans, because actually selective growth restriction is more common in the late second and third trimester of pregnancy in monochorionic twins. So it's recognized that we continue 2 weekly scans all the way through to elective delivery a week earlier than in dichorionic twins at 36 weeks of gestation, to again try and avoid the increase in perinatal mortality after this gestational age. So both screening regimens for both dichorionic and monochorionic twins involve a detailed anomaly scan at 20 weeks gestation. And this is because congenital malformations are more common in twin pregnancies overall than compared to singleton pregnancies. And in particular, they're more common in monozygotic twins than dizygotic twins. However, it's impossible to identify twins by zygosity, although monochorionic twins are always monozygotic. You remember I said that about a third of dichorionic twins are monozygotic as well. So we don't differentiate between the detailed scan at 20 weeks gestation based on chorionicity. And indeed, both dichorionic twins and monochorionic twins are offered an extended fetal echocardiogram to exclude the increased risk of congenital heart disease. These data, and this is a rather busy slide, is from population data from the northeast of England around Newcastle and the northeast. And that is a population-based study where there is a denominator data of all twins for this period of time. And they looked at twins and noted again that the anomaly rate of almost all systems was significantly higher in twins than compared to singletons. But when you looked at the difference in risk between monochorionic twins to dichorionic twins, there were those associated with vascular problems such as TRAP sequence and twin-to-twin transfusion syndrome, but also an increased risk of central nervous system abnormalities and musculoskeletal anomalies as well as chromosome abnormalities. So monochorionic twins have some increased risk of congenital malformations over that of dichorionic twins. And it's very important that we screen for these in the mid-second trimester at 20 weeks. I indicated that many of the problems associated with monochorionicity are due to the presence of vascular anastomosis on the placenta. And there are three different kinds: arterial venous anastomoses, which are usually unidirectional, venous-venous, and arterial anastomoses. And there are no deep anastomoses within the placenta, but often the anastomoses may dive into a cotyledon and conjoin within that cotyledon. And this leads to an excess of very pathological conditions that can complicate monochorionic twins. Twin-to-twin transfusion syndrome affects approximately 10% of monochorionic twins. Twin anemia polythythemia sequence affects approximately 5% of monochorionic twins. Selective growth restriction, 10%, and then transfusional problems that can lead to single or double twins demise affect approximately 2.5% of monochorionic twins. And I'm going to talk about each of these in turn. So twin-to-twin transfusion syndrome affects approximately 10% of monochorionic diamniotic twin pregnancies. It's not very common in monochorionic monoamniotic twin pregnancies, usually because the latter have large arterial anastomoses, which are thought to protect against the development of this syndrome. It is an ultrasound diagnosis that really is based upon whether or not there is discordant Lycol volumes between the two monochorionic twins. And the recipient twin has increased Lycol volume, which is said to be diagnostic if it is greater than 8 centimeters before 20 weeks as a deepest vertical pull, or greater than 10 centimeters after 20 weeks of gestation, and a donor having an amniotic fluid deepest vertical pull of less than 2 centimeters. And that basically is the diagnosis of twin-to-twin transfusion syndrome. And despite only affecting 10% of monochorionic twin pregnancies, it's responsible for nearly 80% of the mortality. The prognosis for the twins overall is affected by the Quintero staging, and Ruben Quintero published these data looking at the basically fetal hemodynamic and cardiodynamic effects within the twin-to-twin transfusion twins back in the late mid-1990s. And so, as well as discordant glycol volume, the donor or recipient fetus can have increased placental vascular impedance by absent or reversed end diastolic velocity on umbilical artery duploinsulination. There can be poor visualization or absent visualization of a bladder, often because of poor perfusion of the kidneys in the donor. And then as you go through the worsening stages from stage 1 to stage 3, you also increase the risks of abnormalities in recipient fetal cardiac function by tricuspid regurgitation often being present, and factors that affect both preload and afterload, such as abnormalities of the ductus venosus waveform, in particular reversed flow in the ductus venosus during atrial contraction, through to the development of fetal hydrops, most commonly in the recipient twin, and then fetal demise as being stage 5, which is obviously beyond treatment. So we often treat stage 1 to stage 4 disease. And the treatment, the gold standard treatment, is that of fetoscopic laser ablation. And this involves, under local anesthetic and often some maternal sedation, the percutaneous and ultrasound guided insertion of a 2 or 3 millimeter fetoscope into the recipient amniotic sac, and visualization of the vascular anastomoses as they cross the intertwin membrane, and then allowing a diode laser to ablate the anastomoses as they cross from one twin to the other across the intertwin membrane. And there is the gold standard way of evaluating treatment is not by individual studies, but to look at things like the Cochrane database. And myself and colleagues were instrumental in looking at these data in the Cochrane database and recommending fetoscopic laser ablation being the best treatment for indeed all stages of twin-to-twin transfusion syndrome, stage 1 to 4. Subsequently, Yves Ville and colleagues in Paris have actually looked specifically at stage 1 disease, and a significant number of twins, monochoric twins with stage 1 twin-to-twin transfusion syndrome, actually either regress or remain stable. And therefore, it is a reasonable option in stage 1 disease to defer treatment until there are signs of progression to stage 2 twin-to-twin transfusion syndrome onwards. So fetoscopic laser ablation often leads to an improved survival for 1 or 2 babies overall, and you can see these data are for the data from our unit for last year. And in over 90% of monochoric twin pregnancies with twin-to-twin transfusion syndrome, they were complicated. They had at least 1 twin surviving, and that broke down to nearly 60% having 2 twins surviving, about 30% single survivors, and about 8.6% sadly double fetal loss. And that compares very well to, you can see this forest plot on the right hand side of the screen, to the data from systematic reviews looking at the outcome in fetoscopic laser ablation for twin-to-twin transfusion syndrome. However, despite good survival these days, there have been concerns that twins may well have an excess risk of severe cerebral morbidity. And the group from Leiden, led by Dicky Kiz and Enrico Loperoli, looked in a prospective study at the risk of severe cerebral morbidity in twins treated by fetoscopic laser ablation for twin-to-twin transfusion syndrome, and also uncomplicated monochoric twins, and found the risk of cerebral morbidity 8.6% in fetoscopic laser ablation from twin-to-twin transfusion syndrome, but nearly 7% in monochoric twins that were uncomplicated when followed up into in infancy. So the excess risk is probably in the order of about 3 to 4%. Most of this risk is from prenatal ischemic vascular events causing ischemia or in some cases intraventricular hemorrhage. And these are most strongly associated with either recurrence of twin-to-twin transfusion syndrome because of unlasered anastomoses, or the development of twin anemia polythythemia sequence, or as a recent American Journal of O&G paper denoted, if there is single intrauterine death. But multiple various analysis in our data and the data from the group in Leiden noted that actually it was the gestational age at delivery which was the greatest risk of babies having cerebral morbidity. And laser ablation prolongs the twin pregnancy longer than any other treatment, and therefore is associated with the lowest risk of cerebral morbidity. So the whole gambit of this treatment is to try and prolong the gestational age of the twin pregnancy until at least 36 weeks gestation if possible. Now, I mentioned twin anemia polythythemia sequence, and this can occur in uncomplicated monochoric twin pregnancies and is said to complicate about 2% of monochoric twins. But the vast majority of twin anemia polythythemia sequence affects complicated monochoric twins, whether it be by growth restriction or by twin-to-twin transfusion syndrome that's already been treated successfully by fetoscopic laser ablation. And this is, or used to be when it was first described, just noted at birth by a difference in fetal hemoglobins or neonatal hemoglobins between the twins of greater than 5 grams per percent. And you can see that one baby here is pink and polycythemic, and the other baby here is anemic. The etiology of this is not identical to twin-to-twin transfusion syndrome, but is caused by hair-like anastomoses that are less than 1 millimeter in diameter and cause a flow as a low transfusion of blood from one twin to the other. And you can see this in the placenta at delivery, with one side, one placental territory being polycythemic and the other being anemic. And this can be screened for in utero by using middle cerebral artery peak systolic velocity measurements in both twins. And the diagnosis is still classically if the middle cerebral artery peak systolic velocity in one twin is greater than 1.5 multiples of the median, and in the other twin, it's less than 1 multiple of the median in the absence of recurrent twin-to-twin transfusion syndrome. There has been some, if you like, improvement in this diagnostic definition, and the group from Leiden refining the definition so that difference in middle cerebral artery peak systolic velocity is greater than 0.5 multiples of the median. But it's a diagnosis based on ultrasound, and classically the umbilical, amniotic fluid, deepest vesical pores are normal. And this can be staged like twin-to-twin transfusion syndrome with worsening difference in middle cerebral artery peak systolic velocity being associated with increasing stage and stage 3 disease when the often anemic fetus has cardiovascular compromise, ending eventually in high drops or indeed death. So again, it is important to stage the condition, and that really does help when you're considering the treatment options. So the clinical relevance of this is that the anemic fetus can die because of associated high drops, hypoxemic brain injury and death, but also the polythythemic baby is also at increased risk with hypoviscosity syndromes and thrombosis of limbs, and increasingly even in babies that have not got this very high polythythemic association with hypoviscosity, being increasingly associated with hearing loss, long-term neurosensory hearing loss. The treatment of this condition is really by, I guess, in the lion's share, by prevention, by using the Solomon technique to treat twin-to-twin transfusion syndrome and a relatively non-selective technique to laser across the vascular anastomosis. However, once it occurs, there is no evidence base to choose between expectant management, in utero transfusion, or indeed in exchange transfusion in some cases, or laser therapy. And these data were from the Leiden group, showing a prolongation of gestation in those babies that were lasered. But again, the numbers were very small. Now, there have been data that's published since this paper looking at outcomes in over 1,000 cases of twin anemia polycythemia sequence from a multi-center retrospective study. But again, it really wasn't definitive about guiding the management of TAPS. And it's very individualized even today, based upon the severity of the difference in middle cerebral artery peak systolic velocity, the gestational age at when it occurs, and indeed things like, is the placenta anterior or posterior? So it is very non-evidence based and individualized even to this day. But as I've said, prevention is better than cure, and certainly in those pregnant monochoric twin pregnancies that are complicated by twin-to-twin transfusion syndrome, both randomized controlled trials and a meta-analysis of all the trials looking at the technique of Solomonization of the placenta have indicated that this significantly reduces the lion's share of TAPS. So prevention is better than cure. When I first set up our twin service back in 2000 in Birmingham, the majority of our referrals for complex monochoric twins was twin-to-twin transfusion syndrome. But increasingly, an increasing number of referrals have come because of selective growth restriction. And you can see that that can affect both dichorionic and monochoric twin pregnancies, but it's much more common in monochoric twin pregnancies. And it has a definition that the estimated fetal weight difference between the twins and ultrasound is greater than 25%, but the abdominal circumference or estimated fetal weight of the smaller fetus is less than the 10th centile. And also, additionally, that there is a decreased growth velocity in the smaller twin. This is associated with, yes, the presence of vascular placental anastomoses, but also because of the difference, percentage of the placental territory of the single monochoric twin placenta. And you can see here the appropriately grown baby in this injection study having about 80% of the placental disc, whereas the growth restricted placental territory of being about 20%. And data from a group in Taiwan, publishing them back in 2009, noted that when you looked at injection studies in growth-restricted, selectively growth-restricted monochorionic twins, that the outcome of the pregnancy was worse, with worsening abnormal Doppler velocimetry in the umbilical artery vasculature, and also by estimates of increasing difference in placental territory between these twins. And the babies that had the worst difference in placental territory and the greatest difference in estimated fetal weight, often associated with abnormalities of umbilical artery Doppler velocimetry in the smaller baby, had increased perinatal mortality and morbidity. The role of arterial anastomosis is very important in selective growth restriction in monochorionic twins, and indeed the presence is almost always there, and there leads often to a prolonged latency between the diagnosis of selective growth restriction in monochorionic twins and decompensation that requires delivery. And that latency period can be as long as 10 to 12 weeks. The fetal risks, though, of selective growth restriction are the risk of intrauterine death of the growth restricted twin, but also of the other twin itself, because the risks of early delivery and therefore perinatal morbidity, with increasing numbers being delivered before 30 weeks and needing a longer duration of treatment on the neonatal intensive care unit, and also neurodevelopmental morbidity, not just if there is single twin demise, but also it's increasingly noted that in the smaller or indeed the bigger fetus, there can be neurologic morbidity even in surviving fetuses into the third trimester. So the management options are expectant management, selective umbilical cord occlusion, in other words, selective termination of pregnancy, or selective laser photocoagulation, so fetoscopic laser ablation. This can be technically difficult and indeed may not always be technically feasible if there's a large anterior placenta. And of course, it wasn't designed to treat selective growth restriction. It was designed to treat twin-to-twin transfusion syndrome. And therefore, there is controversy about whether or not this should be used or not. Certainly, the group in Barcelona, led by Eduard Goretzkas, used a classification for selective growth restriction based upon the presence or indeed difference in umbilical artery Doppler velocimetry in the smaller fetus. Type 1 disease, when the difference in estimated fetal weight is greater than 25% and one baby is small. Type 1 disease is where both babies have positive end diastolic velocity and umbilical artery Doppler insonation. And that, compared to the other two types, has a relatively good prognosis with probably 96% of these twin pregnancies progressing beyond 32 weeks gestation, and the mortality and neurological sequelae being less than 4%. So that group have a relatively good prognosis, and often fetal medicine subspecialists choose expectant management. Type 2 classification of selective growth restriction in monochorionic twins is where the smaller twin has absent or reversed end diastolic velocity. And these cases have a high risk of deterioration, with 90% of them showing decompensation requiring delivery before 30 weeks of gestation. And you can see that the single intrauterine death rates and double intrauterine death rates are relatively high at 30%. And that's reflected in the neurologic sequelae and morbidity that occur in these twins. Type 3 classification is where there are high rates of decompensation, often around 30 weeks of gestation. But when you actually perform umbilical artery Doppler intonation in a smaller twin, you actually get a cyclical change with some of the waveforms having reversed end diastolic velocity and then going back to positive end diastolic velocity. And that's thought to have similar outcomes to type 2, but has a particular increased risk of neurologic morbidity in the appropriately grown baby. And many people group these type 2 and type 3 together in terms of treatment. So I've indicated in type 1, selective growth restriction, often fetal medicine subspecialists treat the patients by expectant management, and often they monitor them every week all the way through their pregnancies, and only about 15% of these will progress to become type 2 or type 3. And they usually have a good outcome, but of course they can decompensate suddenly. And if that sudden decompensation occurs, there is that risk of unexpected single intrauterine death or double intrauterine death. And also there's the additional problems of development of other pathologies such as twin anemia, polythythemia sequence. In terms of type 2 and type 3 selective growth restriction in monochoric twins, then there is often a consideration for selective termination of pregnancy or fetoscopic laser ablation. The data on the management outcomes of these are controversial, and I've already indicated from the Graticus data that there is an improvement in the survival of at least one baby intact, but the smaller baby, when treated by laser ablation, has very high risks of single twin demise. And this again was outlined and described by the group from Paris that separately looked at their own data in the management, the active management of selective intrauterine growth restriction with abnormal Dopplers in monochoric diamniotic twin pregnancies, often diagnosed in the second trimester. And they, in these babies, looked at the relatively small cohort of the outcomes for cord coagulation for selective termination compared to laser ablation. And you can see that the outcomes, again, are relatively equal, except that the cord occlusion have higher risks of amenorrhexis, spontaneous preterm premature rupture of membranes, and therefore miscarriage. But laser ablation is associated with nearly a 50% survival in smaller twin death. And therefore, in the Parisian group, they prefer to manage these cases, if they're early onset, before 24 weeks, by selective termination of pregnancy. However, it's not as straightforward as that, because selective termination of pregnancy, for instance, in many countries around the world may well not be a legal option. And indeed, even if it is a legal option, selective termination of pregnancy, whether it be by bipolar cord occlusion or by radiointerstitial thermal ablation, carries potential risks on its own, not least of which co-twin demise, but also neurologic morbidity that can track into survivors and may not just be anatomical neurological abnormality, but it may be behavioral abnormalities that can be quite morbid for surviving babies going forward. Other pathophysiological conditions in monochorionic diamniotic or monochorionic monoamniotic twins that can cause problems and require treatment is twin reverse arterial perfusion sequence. And this is due again to abnormalities of placental anastomoses that can join the two circulations and often lead right in the first 4 weeks of pregnancy to the vascular disruption of one of the monochoric twins. Often these twins have no head and no brain and no beating heart. So theoretically they are not alive, but they are kept alive by the pump twin, which perfuses the acardiac twin through by reverse perfusion through an anastomosis, which is where the name comes from. As I've said, 70% of these are monochorionic diamniotic and 30% are monochorionic monoamniotic. The outlook is really dependent upon the size of the acardiac twin and whether or not there are signs of any cardiovascular dysfunction in the pump twin, in other words, the normal twin. So ductus venosus insonation, umbilical artery Doppler sonation in the pump twin, and also cardiodynamic assessment by ductus venosus waveform and tricuspid regurgitation and cardiodynamics is again worthwhile to try and identify those fetuses that are at risk and to intervene early, because there's some evidence that intervening early, even in the first trimester by intrafetal laser, may well improve the outlook for these babies. These are figures from Birmingham Women's Hospital. And again, you can see the forest plot showing that when you don't intervene in a trapped pregnancy, then survival of the pump twin is about 55%. All intervention, the survival of the pump twin increases to about 75%. Cord occlusion reduces the survival compared to intrafetal occlusion by either radio interstitial thermal ablation or by intrafetal laser, mainly because of the fact that cord occlusion with bipolar diathermy has higher risks of prelabor premature ruptured membranes. Overall, there's a 76% survival of the pump twin, which is significantly increased survival over no intervention. So finally, I'm going to touch upon the problems of when one fetus dies in monochorionic twins and the impact on its co-twin. And this could occur spontaneously, but also it can occur in any of the pathologies of monochorionic twins that I've actually mentioned, whether it be twin-to-twin transfusion syndrome, twin anemia, polythythemia sequence, or selective growth restriction. And if one baby dies, then immediately the pressure in that fetus from its heart falls away to 0, and the twin that's alive has a high pressure, and therefore blood can flow through the placental anastomoses from the living twin to the dead twin, leading to either acute or subacute anemia or hypovolemia. And this can cause problems in the surviving twin, and that way will have profound consequences for the surviving monochorionic co-twin. When this is diagnosed, it is important that such twin pregnancies are referred urgently for a fetal medicine opinion, usually at a tertiary referral center, where middle cerebral artery peak systolic velocity can be assessed in the living baby, and also a detailed scan performed to exclude acute evidence of brain damage from ischemia. If there is evidence of fetal anemia in the twin that is surviving, then in utero transfusion has been demonstrated to improve survival in the twin, but it doesn't seem to have an actual beneficial effect in reducing neurologic morbidity long term. And indeed, in a letter in the Journal of Ultrasound and Obstetrics and Gynecology published this month, the group from Leiden actually indicated in a relatively small cohort that they questioned whether or not in utero transfusion should be offered in this condition because the outlook was so poor overall. Even if the normal baby shows no signs of anemia and there is no initial signs of brain ischemia, serial ultrasound is required at weekly intervals to look to see if there's developing neuroischemia, and adjuvant fetal MRI scanning of the fetal brain is useful, often between 14 and 28 days after the sentinel event. The data in looking at the outcomes in these particular pregnancies is skewed by retrospective and a small number of prospective, but cohort studies which are confined to tertiary centres. And there is a desperate need for regional databases to collect these data with denominator data so that you actually have accurate data on outcomes and pathology. However, when you look at the literature and combine it in a forest plot and meta-analyze the outcome, you can see that in monochoric twins with single twin demise, the risk of co-twin demise is 15%, compared to if it happens in dichorionic twins, 3%. So significantly increased risks of co-twin death in monochoric twins compared to dichorionic twins. And that's not surprising, bearing in mind the conjoining of the circulations. Also, in terms of neurodevelopmental morbidity going forward, the risks in monochoric twins are significantly higher, as high as 26, some studies as high as 30% have risks of neurodevelopmental morbidity, whereas in dichorionic twins, only 2% of surviving twins has neurologic morbidity, and much of that is because of iatrogenic preterm delivery. So I've gone through, I hope, why twins are at increased risk of perinatal mortality, and in particular, the focus upon chorionicity and the adverse effects of monochorionicity on twin outcome. I've not obviously touched on preterm birth, which in itself affects both monochoric twins and dichorionic twins. And the majority of twins are delivered before 37 weeks of gestation, and a significant number, perhaps 70%, are delivered before 34 weeks of gestation. Perhaps using cervical screening by cervical length at 20 weeks gestation may identify those twins that are at increased risk of preterm birth, but we're at a severe disadvantage in that none of the interventions that we have in our armamentarium, whether it be high dose vaginal progesterone or whether it be other things like pessaries, they all seem to not really have an improved outcome in risk twins at risk of preterm birth. Now that's slightly controversial. I know that Kipros is very keen on using high dose vaginal progesterone, but really the only intervention that's shown to have any significant major effect is in those babies that have those twin pregnancies that have very short cervix, 20 to 24 weeks gestation, less than 1 centimeter, and then cervical cerclage is probably the best option. But then that hasn't been proven in a randomized controlled trial. So thank you very much for your attention today, and I'm very happy to take questions, but thank you for inviting me.
Thank you. Thank you very much, Professor Kilby, for taking us so deftly through those absolutely dazzling slides and that fantastic content. You have truly made it so simple for us to now start thinking systematically about twins right from the beginning. And I do hope this is going to have an impact on the way obstetrics is practiced in India from tonight onwards. We have had a major problem with our stillbirths. We've had an even greater problem with managing stillbirths in multis, and we do hope this goes a long way in helping that. We have a lot of questions in the chat box, but before we start on that, thank you indeed for all the time you've given us today and making it truly so simple for us. And we do look forward to interaction in the future as well. And with that, over to the second part of our session today for the questions and answers. I can see that the chat box is quite full. So over now to Dr. Rima Bhatt and to Dr. Parna Sharma for taking over our question and answers.
Thank you, sir. And thank you, Professor Kilby, for that absolutely wonderful lecture. I think you covered the topics so very well. And and I must tell you that at one point in time, at least there were 200 listeners. So I think it was very well received and lots of appreciations and a lot of questions. And three things that, we started at is the impact of chorionicity, like the way you said that, in fact, when you looked at it, some things actually improved. The stillbirths in some parts of the twins actually improved. So the impact of chorionicity was well taken. So that is a message for our population as well. And the second part was the twin clinics. So like sir said, that maybe a part of the practice of twins in India might improve from tonight. So that message is something that we want to take back as the twin committee, stillbirth committee in twins and SFM together. So with that, we'll be very honored if you'd like to, answer some of our questions.
Yes, of course.
Yeah, so we begin with.
I think it's very, I think there is little doubt that multidisciplinary twin clinics with obstetricians and midwives that are interested in the management of twins and have built up expertise in the management is extremely important, but also others like sonographers that have an interest in looking after twins and all the other multidisciplinary services. And there's, some indirect evidence from the Twins Trust in the United Kingdom indicating that those trusts that have embraced the NICE guidelines and instituted multidisciplinary twin clinics have better outcomes. Now, it's very easy for me to sit here in the UK and say that this should happen and it should happen, but there are obviously going to be logistic, not least of which geographical logistic problems that you will face in England and in India. And I wouldn't want you to go away with the idea that we are doing everything perfectly, because when I looked at the Embrace annual report for stillbirths, there was evidence that in at least 65% of hospitals that were providing care for twins, they weren't using multidisciplinary clinics. So there was a lot to do in the UK as well. So you shouldn't feel too bad the fact that your aspiration to set up multidisciplinary twin clinics, I think, is a good one, because I think it does have an impact. But we have a lot to do still in England and the UK.
Thank you for those words, sir. And we are very optimistic because we know we are beginning it, and we are at a very good place with societies like Society of Fetal Medicine and Stillbirth Society, where we are planning to bring fetal medicine and obstetricians together so that we communicate, we have a dialogue between the two, so that the radiologist, and the most important aspect is refer. Everybody doesn't have to treat twins. We diagnose a problem and we refer. So, sir, with that, I'd like to start with the first question, where Dr. Jay is asking if we can comment regarding the chorionicity as early as 6 weeks, looking at the yolk sac.
Well, I think you can there by transvaginal ultrasound scanning, there by counting the number of placentae and looking at the thickness of the membrane and looking at yolk sacs, it's possible in the mid first trimester to be able to define chorionicity. But I think the reason we indicated that chorionicity is best assessed at 11 to 13 weeks is because you want to be everyone only has so much resource, and at the first trimester scan, which is because a woman doesn't come pregnant saying that I've got twins, the ultrasound scan will tell you whether she's got twins or not. Now, many patients will come through infertility clinics when they will have early scans, and you will know earlier on, but many won't. And so by setting out that all women should have a scan in the first trimester, and that really between 12 and 14 weeks gestation, that means you can, 1, diagnose twins, 2, date the pregnancy, 3, look at the chorionicity, and that's the time when it has the best sensitivity and specificity of being able to define chorionicity, and then offer first trimester combined screening if that's what the parents wish. So that's why it's done at that gestation. But of course, if you have the resource, then you can do it earlier.
Thank you, Professor. There's another question by Dr. J. He wants to know, till what period of gestation is it safe to selectively terminate a fetus by KCL in case of BCDA twins?
Sorry, your
Till
question
what
broke.
period of gestation?
So till what period of gestation is it safe? So till how long can we terminate a dichorionic twin? Like till what gestation, the higher limit?
To be honest with you, it depends. So the honest answer to that question is, excuse me, is about 22 weeks gestation. That's when the risks are smallest, because you can vascularly ablate the connections either inside the fetus by intrafetal laser or by radiointerstitial ablation. Sorry. Sorry. Thank you. But you can perform cord occlusion right up into the 3rd trimester. It just becomes more difficult and more problematic because the placenta, the cord is often very thick and it can be difficult to ablate. And also incomplete ablation will lead to death of the co-twin. So in all honesty, in reality, it's up to about 22 to 24 weeks. But you can, in exceptional circumstances, do it later if the law allows it. But it has more complications.
Right. Yeah, thank you, sir. So there is this question which says that, is the cord insertion a determinant for selective growth restriction? Does the insertion of cord determine if the baby is going to be a selective growth restriction?
There is some evidence that filamentous cord insertions are associated with increased risk of selective growth restrictions, yes. But of course, filamentous cord insertion occurs in twin-to-twin transfusion syndrome as well. And there is a sort of, it's like a Venn diagram, right, between twin-to-twin transfusion syndrome, selective growth restriction, and in inverted commas, uncomplicated twins. And there's an overlap between them. Right.
So, and there's this question, why not add cervical length from 16 weeks onwards? So, because in your chart, it was mentioned that do cervical length at 20 weeks.
Again, it was just done because it was plotted within these scans are that NICE have outlined are available to every woman and irrespective of whether you can pay for it. They're not charged. They're within the National Health Service. So it's just a way of being able to manage the resource.
Right. So again, so the question would, sorry, Dr. Rima, is your speech volume? Yes.
So, can you hear me, sir?
Yes, yes.
Do you do a routine fetal echo in dichorionic twins as well? Is it a routine, sir? Or is just the monochorionic twins that you do a fetal echo for?
So you're echoing when I can't, sorry, I can't understand.
Dr. Rima, I think you remove the.
So Dr. Aparna, take the question.
Yeah. So, remove the headphones. Yeah. So, Professor Kilby, sir, do we advise fetal echo for all dichorionic twins as well, or it is only for the monochorionics?
Do I advise people to?
Fetal echoes, fetal echo. Routine.
Oh, yes, yes. In the UK, all fetuses at 20 weeks gestation have a fetal echo. So the FASAB views are 4-chamber view, outflow tracts, aortic arch, and a 3-vessel view. So that is what's offered. That's what we mean by a fetal echo, both for twins. And because up to 30% of dichorionic twins are monozygotic, we don't differentiate between the two. So all twin pregnancies are offered that detailed echo at 20 weeks by a sonographer. They don't need to see a cardiologist. They have it by a sonographer.
Right. Okay, sir. Sir, and then what about the quintero staging, sir? Is it common to have stage 3 like absent and diastolic flow without stage 1 and 2?
Yes. So there isn't a neat progression from stage 1 through to stage 5. So if you just watched it, it wouldn't necessarily go 1, 2, 3, 4, and then 5. Often patients present with stage 3 disease. You know, they had apparently normal ultrasound scans the week before, and then they present with severe discordancy in lichal volume, and there's the ductus venosus or umbilical artery Doppler dosimetry is abnormal. So yes, it is very variable how it presents.
Thank you, sir. So does the size of the trap twin, is it clear now? So the question, does the size of the trap twin has a significance in the management plan of the pregnancy? Or
Yes.
the size does not matter?
Yes, no, the size matters very much, because if the trap twin is large or equal in size to the pump twin, then there is a very high probability that the pump twin will develop cardiac compromise and die. So the larger the acardiac twin, the greater the need for intervention. And you get some idea of that as well from the, so the majority, when I first was appointed as a consultant in 1996, most traps were seen at between 22 and 24 weeks of gestation. These days, they almost all are diagnosed in the first trimester scan, the first scan. A few of them, there is some confusion about what they're dealing with and whether or not this is intrauterine death and a viable pregnancy, but usually the penny drops within a week or so. And so it's very unusual to have traps referred after 16 weeks gestation. Most of them are seen within, 13, 14, 15 weeks.
Right.
And it is important because the presence of cardiac compromise in the pump twin at diagnosis and the size of the acardiac twin, both of those things will define whether or not you would just manage the pregnancy expectantly or whether you would intervene.
Sir, regarding intervention in traps, when do you intervene ideally? In the first trimester, or do you wait for some time?
No, well, I think there's been a change in the way that people manage them. If it's diagnosed in the first trimester and there's a need for therapy, I think there's evidence that you can lose about 25% of pump twins between diagnosis in the first trimester and waiting until 16 weeks. So many will intervene by intrafetal laser. And try and ablate the circulation between the twins in that way. And that's the reason for that.
Right. Sir, and there's this question which says, when is the earliest TAPS can manifest as a primary complication?
Well, the earliest I've seen it is at 16 weeks gestation. But of course, it can become it can be, as I indicated in my lecture, it can be quite difficult to choose what is the best treatment. And depending on the severity of the middle cell artery peak systolic velocity difference and the gestation will depend on how you manage the condition. But the vast majority of them, if you plot them out, the number of TAPS compared to with gestational age, there's almost like a bimodal presentation, and there was a peak at about 22 to 24 weeks, but the biggest peak is about 28 to 30 weeks, and that's because of the association with post-laser TAPS.
Sir, what growth charts would you prefer to use for assessment of growth in twin pregnancies? The growth charts.
Yes, there is a lot of debate, as you know, about that. I think, being honest, probably the intertwin charts are probably the best, but the Twins Trust do have a set of charts that are derived from multiple twin pregnancies that can be utilized. I think either of those two are better than using the GROW chart.
So I think there are some questions which say that what is the cause of intermittent, absent, and reverse and diastolic flow in twins, and this has been covered specifically in the various conditions.
Yeah, I think it's an anomaly due to the presence of different vascular anastomoses between the two fetal circulations and the presence of arterial anastomoses. The velocity being reflected back can cause that if you like, cyclical appearance of the waveform. So it's almost pathognomonic of there being AA anastomoses, which are for the most part protective, but of course can cause problems in terms of neurodevelopmental morbidity once you get past a certain stage in pregnancy.
Right, sir. So I think most of the questions have been covered. Just the last few questions is how to differentiate SFGR associated with Doppler abnormalities from TTTS without Leica abnormalities. Although I don't know how TTTS can exist without Leica abnormalities.
Yeah,
but
I think it's very important that, you know, if there is normal Leica, then the Doppler velocimetry abnormalities are likely. The greatest probability is that as the pregnancy is followed up, it will be associated with selective growth restriction. But it's also that it could be prodromal twin-to-twin transfusion syndrome. So either way, you would follow the patient up very carefully, but it's much more likely that it will be develop into selective growth restriction than twin-to-twin transfusion syndrome. The definition of twin-to-twin transfusion syndrome, as I emphasized, is that discordance in Leica volume.
Yes.
That's the key.
yes.
Sir,
Yes.
okay, there's another question, sir. Is in early monochorionic pregnancy, does the number of yolk sac determine the number of amniotic sacs? So the number of yolk sacs, is it related to the number of amniotic sacs? That's the question.
Not necessarily, I don't think, because the yolk sac is usually associated with the fetus itself, and it doesn't always follow that it will develop into amniotic, you know, an amniotic sac. I mean, often it does, but it's not an absolute association.
Right. Sir, there's this very practical problem that you come across that, I mean, we come across that first trimester chorionicity has not been done. So how the second trimester placenta is fused?
Yeah, I think if the chorionicity hasn't been allocated in the first trimester, then it needs to be assessed by an expert who can try and do it in the second and later on in pregnancy. But at the bottom line, if you can't decide whether the baby is the twins are monochorionic or dichorionic, then you treat them like monochorionic.
Yeah. Yes, sir.
And that would be the safest option.
Yeah, thank you, sir. Sir, one last question, just for the sake of knowing it, sir. Can you tell us like the complications that have happened, like really with the interventions, sir? Have you come across something like the amniotic bands after interventions, or?
Well, I mean, we're always concerned with intervention. So fetal therapy, whatever it is, there can be maternal complications, and hopefully they are very rare. But at all of these things, the greatest risk is abruption, placental bleeding, and infection that can be introduced. So they're the two big things. And then fetal problems as well. So the obvious, most common problem associated with both the condition that has caused the fetus or the fetuses to be considered for fetal therapy, but also the therapy itself can be single or double twin demise, and then ruptured membranes, amenorrhexis. And then can be membrane separation, which increases slightly the risk of preterm birth. And there have been described amniotic bands that can actually entangle the limbs of a baby and require to try and release them by laser or scissors. But they're relatively rare. I've only seen those complications very infrequently. We've done over 1,000 lasers now since 2000, and I've only seen them once or twice.
Right, sir. So thank you very much. I think we've covered all the questions. There have been lots of appreciations. And yes, for the people, I think they've requested a recording. And yes, it will be available on the SFM website.
That's absolutely fine. And thank you very much for inviting me. I hope that now COVID is abating, if that's what it is doing, that it won't be long, but hopefully I can visit you in India, in Delhi, rather than just seeing you on Zoom. But it's very kind of you to invite me to give the presentation this evening. Thank you.
Thank you very much, sir. And I now invite Dr. Reema Bhatt to please take the program forward.
Thank you so much, sir, for this wonderful session. I would now request Dr. Nusrat, who's the Vice President of the Stillbirth Society of India, to put forward the vote of thanks. Dr. Nusrat.
She was there, Dr. Nusrat.
Yeah. Thank you. I was not able to unmute myself, so sorry for that little problem. So thank you, Dr. Reema and Dr. Aparna, for giving me this one. Big thank you, Professor Kilby, for a very useful and an interesting session, for agreeing to be our speaker and for your valuable time. The advanced research guidelines and concepts done by fetal medicine experts like you has to reach a large majority of baseline clinicians like I am. I'm not a fetal medicine specialist, but we are the ones who come in contact with the twin pregnancy first, and it is very important for us to understand. So this session was very important for dissemination of possibilities at what can be done for fetal salvage in twin pregnancies. Many times we just overlook, say, thinking that nothing can be done. A big thank you, Dr. Purana, for your valuable expertise, Dr. Aparna, Dr. Reema, and the entire committee for making this session possible. Dr. Tamkin and the Stillbirth Society team for all the hard work that goes in behind the scenes. And I think the most important gratitude goes to all those who logged in today in a big number for your questions, for the interaction, and you really contributed to the learning. We enjoyed your questions. So on behalf of all of us at the Stillbirth Society of India, a big thank you and a good night.
Thank you very much. Thank you.
Thank you.
Nice to see you all this evening, and have a good summer. Bye-bye. Maybe I'll see some of you at the Fetal Medicine Foundation meeting in Crete, but maybe not. Hopefully soon anyway. Bye-bye.
Bye, sir.
Thank you.
Thank you very much.
So much.
Thank you.
Thank you.